With that, I'm going to introduce our speaker for today, Dr. Jeff Kullgren. He is an assistant professor here at the University of Michigan in internal medicine and at the Center for Clinical Management Research at the VA. And he is a former clinical scholar, not here at University of Michigan, but from the University of Pennsylvania's RWJ Clinical Scholars Program. And he is an expert in behavioral economics as it's applied to medical interventions. And he uses the principles of behavioral economics to develop scalable interventions to help patients and clinicians make better decisions. But he's going to talk to us today about a sort of a new area of his research that's focusing on price transparency and how that impacts patient decision making. So I'm looking forward to learning from it, and we'll let you take it from there.
All right. Well, thank you, Caroline, and thank you all for being here today. And so I'm thrilled to be able to talk to you about helping patients in high-deductible health plans get the care they need at a price they can afford. So I've got 3 objectives for the talk today, and I will try to save about 10 minutes at the end for questions, and then happy to continue to have dialogue with you afterwards if you're able to stay. The first objective is to examine the growth of enrollment in high-deductible health plans, help you better understand what that looks like currently across the U.S., understand some of the motivations and some of the factors driving the growth of enrollment in high-deductible plans. We'll then spend a little bit of time setting the stage, reviewing what we know about the challenges that are faced by patients in high-deductible plans. We know a lot at this point about what patients in those plans face and some of the problems that they create that I'm trying to address in my work. And then I'll close by spending most of the time talking about strategies that we might be able to use to help patients in high-deductible plans get the care they need at a price they can afford. So how many of you would say you are very familiar with high-deductible health plans? I'd say some hands. How many of you have heard of high-deductible plans? Let's go with a lower bar. Okay, so most of you have at least heard of it before. I just want to provide a level set at the get-go in terms of helping you understand what those plans are and what we're talking about. So high-deductible plans are private health insurance plans that have large deductibles. Now, what a large deductible would be for one person may not be the same thing as a large deductible for somewhere else. That line is actually drawn by the Internal Revenue Service, believe it or not. And where that sets at currently is that if one has individual coverage, so that you're the only person in a plan, the threshold for that deductible is $1,350. Now, if you're in a family plan, that threshold is $2,700. So they're kind of weird numbers. High-deductible plans started in 2003. They were actually created as part of the Medicare Modernization Act. That is the same piece of federal legislation that created the Medicare Part D plan, the Medicare Advantage program, also created something called health savings accounts at that time. And so it wasn't the legislation creating high-deductible plans, it was the legislation creating health savings accounts or tax advantage savings accounts that one can only have when you also have a private health insurance plan that is a high-deductible plan. So it was the HSAs starting then, and then in order for you to be able to get an HSA or health savings account, you had to have a high-deductible plan. So just rewinding to the political context of when that started, this was 2003, so this was during the George W. Bush administration, and this was part of the Ownership Society. Okay, it was a big political initiative at that time. And it was the idea that more people should have health savings accounts. They should be able to have tax advantage means for saving for their health care. But at the same time, there were policymakers that were trying to encourage patients to act more like consumers in health care and try to be more judicious in their use of the healthcare system and more cost-conscious in their decision-making. So they kind of paired the two together, and that's how you ended up with high-deductible health plans. Now, those plans are sometimes now linked with a health savings account, but not always. So those plans, when they are offered, are not required to be linked with an HSA, but in order for one to have an HSA, you need to have that kind of plan. So these are data from the National Health Interview Survey, which probably provides the best national data on the rates of enrollment in high-deductible health plans as a percentage of people with private health insurance. And going back to 2010, so again, this is 7 years after this federal legislation created HSAs, you can see that at that point in time, 25% of people, these are non-elderly people with private health insurance as the denominator, 25% of those people at that point in time were enrolled in a high-deductible plan. And you can see here, if you look at the upper part in the legend there, most people at that time, and this is still true today, who have a high deductible health plan do not have a health savings account, even though that kind of plan is eligible to be linked to an HSA. Fast forward to last year, that rate has now grown to 43%, okay, 44% actually. So out of all non-elderly people with private health insurance now, 44% of them are enrolled in a high deductible health plan. So you've seen a 2 to 3% absolute increase in rates of enrollment in high deductible plans as a proportion of private health insurance year over year. If you project that out into the future by 2020 or maybe a little bit thereafter, most people who have private health insurance will be enrolled in a high deductible plan. Okay, fast forward even further beyond that, this will far and away be the dominant kind of private health insurance going far into the future. As I'll illustrate in a minute, there's not a lot on the landscape that would suggest that's going to change anytime soon. So as I talk about all of this going forward, I want you to think about this as something that will be relevant not only now, but far into the future. Just to drill down on that a little bit more to help you understand some of the dynamics that led to where we're at in rates of enrollment in high deductible plans. These are data from the Kaiser Family Foundation and the Health Research and Educational Trust. These are data on employer-sponsored plans. So the private health insurance market is comprised of employer-sponsored plans, exchange plans, and then private plans purchased off the exchanges, essentially. So these are looking just at employer-sponsored plans. And what you see here is the proportion of employer-sponsored plans that have any deductible at all. So there was a point in time when most private health insurance plans did not have deductibles. There was first dollar coverage. Okay, you didn't have anything you had to pay out of pocket for your health care before the coverage kicked in. If you go back to 2006, so 3 years after HSAs were created, just over half of those plans had a deductible. You fast forward to 2016, this is now 83% of private health insurance plans have any deductible at all. If we look then at those deductible amounts, so this is only looking at those plans that have a deductible, and again, that's 83% of plans now, you can see back in 2006, the average deductible amount was $584, okay, out of all those plans with a deductible. In 2016, that had grown to almost $1,500. This is the average deductible amount among the vast majority of private health insurance plans that have a deductible. So we've seen dramatic growth in just having any deductible with your private plan. When you do have a deductible, we've seen dramatic growth of the size of that deductible. Those are employer-sponsored plans. Of course, for private insurance plans that are outside of the employer-sponsored market, there's large deductibles as well. And of course, there's been a lot that's been written about this in the media, especially when after the exchanges have been created as part of the Affordable Care Act. What you see here are the different metal tiers and the average deductible amounts of private insurance plans in each of those different metal tiers. And of course, plans purchased through the exchange, the vast majority of them are either bronze or silver plans. These are the average deductibles in those plans. Okay, if you look at the gold or platinum plans, which are enrolled in at a much lower rates than the bronze and silver plans, the deductible levels are much lower. Okay, so the vast majority of plans that people are acquiring through both federal and state exchanges are indeed high deductible plans. Of course, there are some people for whom there are cost-sharing subsidies, but that's only a very narrow segment of the population that's eligible for those subsidies. So people that are purchasing plans through the exchanges, the vast majority of them are subject to high deductibles. Okay, so hopefully I've convinced you that this is a really common issue and that there are many people that are facing high levels of cost sharing in their private health insurance plans. What's behind this? Well, I think there's two main drivers of the growth of enrollment in high deductible plans. The first you can see here illustrated on this slide. So again, this is data from Kaiser and from Health Research and Educational Trust. This is looking at employer-sponsored plans. And one strategy that employers have been using to deal with the growth of high healthcare costs, of course, is that often they will pass that along in the form of premiums. Increasingly, what they've been doing to constrain premiums is instead push that over as deductibles. Okay, so instead of increasing the premiums, have been increasing the deductibles in those plans. So what you can see here on the lines at the bottom part of the slide, this is from 2011 to 2016, there's been a 19% increase in the cost of premiums over that 6-year time period. You can see that is higher than the rate of increase in workers' earnings, higher than the rate of inflation, but much lower than the growth of deductibles. Okay, so the growth of deductibles over that same time period has been 63%, whereas the growth in premiums has only been 19%. Again, both of those much higher than the growth in workers' earnings and in inflation, but far and away deductibles are growing at a much faster rate than our premiums. And I think one of the other main driving factors behind the growth of enrollment in high-deductible plans has been what has been termed the skin in the game argument. So this is just the belief or the way of looking at the world that when people are faced with high levels of cost sharing, they have more skin in the game, and they will be more judicious users of healthcare. They will be more cost-conscious healthcare consumers. They will use healthcare more wisely and more carefully, and that they might also even take better care of themselves because they don't want to in the future accrue costly health conditions. That is how that line of argument goes. You know, whether you actually believe that or not is a little bit of a, I'll be honest, a political Rorschach test. But be that as it may, that is one of the drivers, and certainly if you look at a more practical level, behind consultants that have been going to employers and have been suggesting that employers, instead of offering their more generous plans, move over to only, in some cases, offering a high-deductible plan. General Motors, for example, did this with their workers and their salaried workers and their retirees many years ago now, actually, where they moved all of them into a high-deductible health plan only. That's called the total replacement approach. You've seen a lot of employers do that now. Some of it, again, is a way to deal with the growth of healthcare costs and not having to increase premiums too much. But also, again, this just belief that people will be better healthcare consumers when they're exposed to those high levels of cost sharing. So I think those are the two main factors that have driven the growth of enrollment in these plans. So how then do these plans affect patients? And that's really the critical issue, I think, and what I've been exploring in my work. This is an area where what's old is new again. So if we go back to the Rand health insurance experiment, which was conducted in the 70s and 80s, remains, of course, one of the most important studies and probably the most important, at least, randomized trial in the history of health policy research. It has some really relevant insights in terms of thinking about the effects of high cost sharing on patients' access to care and on their decision making. So just briefly, many of you have heard of the Rand health insurance experiment, essentially randomized people to different kinds of health insurance plans and then followed them for a number of years into the future. There were several different levels of cost sharing, and then there was a free care plan. One of the policy questions at that time was, well, what happens when we give people free health care? You don't see that as a policy relevant question as much these days, but that was something that was on the table, of course, back then. If we flip that around now and we say, well, what about the people with high levels of cost sharing? How does that compare to people who didn't have cost sharing, had lower levels of cost sharing? And I think the results from the Rand health insurance experiment remain very, very relevant to this day. Now, what you see here in this figure are different kinds of healthcare that is very, very effective and healthcare that is much less effective. I think in 2018, we would call that high-value healthcare, or we would call that low-value healthcare. And one of the main findings from the Rand health insurance experiment was that when people faced cost sharing, so if you lump together all the plans where people had cost sharing, compare that to the people who had free care, people who had cost sharing reduced their use of less effective care. That's a good thing. People avoided getting care they probably shouldn't have been getting in the first place. Okay, the problem, of course, is at the same time, people also went without getting care that was highly effective. Care for acute conditions, care for chronic conditions, care that was going to help people that they probably should be getting. They got less of that as well. And in fact, they got less effective care and less highly effective care at relatively equal rates. So in other words, people decreased their use of everything across the board, whether or not that care was less effective or highly effective. Fast forward now to the 20 to 30 years since the Rand health insurance experiment and looking at more contemporary plans, we see a lot of those findings echoed in study after study. First of all, we've learned from the research in this area that it is, of course, difficult for patients to differentiate high-value services from low-value services. One challenge in the whole consumer-directed healthcare movement, and when people are talking about consumer-directed healthcare, they're talking about high-cost sharing paired with a health savings account typically. We know that we as providers, and I'm an internist, and us as providers, part of our job is to be an agent for our patients and help them deal with asymmetric information. If you're putting more of that responsibility on the side of the patient, of course, it's not surprising that they're going to have difficulty sorting out what kind of healthcare they should and should not get. But we have a number of studies now saying in these current plans that's a major issue. We know that people reduce needed healthcare due to cost, again, hearkening back to the findings of the Rand health insurance experiment. We know that people in high-deductible plans decrease use of high-priority office visits, long-term medications for chronic conditions, and even use of clinical preventive services that don't have cost sharing. It is complex for people to use these plans and understand what is my deductible and am I at or below it. Some of these plans exempt some services from deductibles. In many cases, people go without clinical preventive services, even when, in this day and age, evidence-based clinical preventive services are exempt from deductibles. People will often still go without those services because of the perceived cost of them. Of course, there are greater adverse financial outcomes that people face in these plans in terms of healthcare debt, ability affording healthcare bills, and the like. We'll talk more about that a little later. These plans do, that being said, lead to lower, at least in the short-term, healthcare spending. Okay, people decrease their use of healthcare. It turns out that they're less costly. And again, this is what many employers are attracted to in terms of offering these plans. And in fact, when we look cross-sectionally, people in high-deductible plans have healthier behaviors. But it looks like that is almost entirely due to selection, or people who are otherwise healthy and engage in healthier behaviors choosing those plans as opposed to the plans encouraging them to be healthy. We also know at the same time that there are particularly vulnerable populations that are increasingly enrolling in these plans. One population that we looked at in a study we did several years ago, back actually when I was a resident in Boston, and this was in partnership with Harvard Pilgrim Healthcare, we looked at the experience of lower income families in high deductible plans. And we define lower income as being less than 300% of the federal poverty level. This was at a time and in a place where there was state-based universal coverage that was trying to be achieved through the connector in Massachusetts. And they drew the line for lower income as being at 300% of the federal poverty level. In terms of that, it's when people were eligible for subsidies to help them defray high healthcare costs. And what we found is that families with lower incomes delayed or went without needed care at much higher rates than did families with higher income levels. And this was one of the first studies to look at the experience of lower income families in these plans and how that relates to them going without needed care. And we looked both at care that was delayed or went without for both children and for adults, and we found that families were going without both of those at higher rates when they had lower incomes. We've also looked more recently at the experience of people with chronic conditions. So you can imagine people that have high healthcare needs, the need for more healthcare, that they would be more vulnerable to the high cost sharing of these plans. It's important to note, and Mark Fendrick is not here today. He's probably out working on this very problem, of course, talking to folks at the Internal Revenue Service that has been really engaged, and some of you have been involved with this, I know as well, engaged with allowing health insurance plans to still be linked to a health savings account, but exempting evidence-based treatment for chronic conditions from deductibles. So introducing value-based insurance design into high-deductible plans. Currently, it turns out that your medications for diabetes and hypertension and all of the rest are subject to cost sharing in these plans. That plans cannot legally exempt those things from deductibles and still be paired with a health savings account. So what we found then is that when people have high deductibles and they have no chronic conditions, one or more chronic conditions, or two or more chronic conditions, that they face much higher rates of what has been termed by the Commonwealth Fund high medical cost burden. So one of the arguments of these plans are, they have high deductibles, but they have a lot lower premiums. So for many people, it may be a better deal. If we look at what people have to pay for their health care, both in terms of the premiums plus the deductibles, and add those together, that's how most people think about their healthcare spending, not just the cost sharing, separate from the premiums, of course. If we lump those two together, we see that when people have high deductibles, that when that amount they're spending on healthcare exceeds 10% of their household income, they experience those high medical cost burdens at much greater rates than people with lower deductibles or no deductibles at all. And this was work with Joel Siegel when he was a doctoral student here and is now in faculty at Penn State as a health economist. So how could we solve these problems? And that's what the work that I'll be talking about for the rest of the time has been addressing. If we step back and think about, okay, how could we deal with these problems? Well, naturally, when people have to pay for a lot of their healthcare out of their own pockets, it'd be nice if we could just make healthcare cheaper, right? I think we're almost there. We're so close to just making healthcare cheaper for people. But theoretically, that could be a solution. That is a longer-term enterprise. And a lot of people in IHPI, of course, are looking at this very problem, but we're still far from being able to realize that promise. I think, of course, we can make health insurance more generous. At the same time, I've showed you trends going in the exact opposite direction, and there's nothing on the policy landscape to suggest we're going to walk back from that. In fact, if it ever actually gets implemented, the Cadillac tax on employer-sponsored insurance plans will make employer-sponsored plans less generous. It keeps getting pushed back further and further, and the House, I think, is poised maybe to do that again. But at some point in time, they probably will have to actually implement that part of the Affordable Care Act. And so it is unlikely that insurance will get more generous in the near term, although, again, you, of course, start to see more conversations about single-payer health insurance. But, again, I think most of us would agree that we are still very far from that being a reality as well. So cost sharing will continue to grow, at least in the short term. We could, of course, make cost sharing smarter. I mentioned some Mark's work and the work of others, trying to implement more value-based insurance design. Reference-based pricing is another tool where health plans will say, okay, we're going to cover this service, but we will only pay so much for that particular service. Let's pair that with price transparency information. And then try to help people better afford needable care and select lower-cost providers. There's been some wins, I think, in the short term in terms of implementing that kind of approach, but in terms of that being a panacea to these problems, I don't think we're quite there yet. Of course, tiered networks as well. Let's have different tiers of networks of providers depending on the value of the care that they provide. I think all of these things, another challenge, of course, getting back to consumers being able to understand their plans, makes healthcare and cost sharing much more complicated. So that's a constant push and pull going on. If we try to make cost sharing less blunt, it will get more confusing for people. And I'll illustrate in a little bit health insurance literacy and how that relates to people being able to use these kinds of plans well. That could potentially be more of a problem if we make cost sharing more complex. So what I've been focusing on is helping people better use high deductible plans. So being a bit of a pragmatist and thinking about we are where we are. You can argue about whether this is good or bad where we're at, depending on where you look at these, the lens through which you look at these issues. Let's take it where it is and let's figure out ways that we can help people better use high deductible plans to get the care that they need at a more affordable price. So what would that mean for people to be able to better use high deductible plans? Well, how many of you I'm not going to call on anybody in particular, how many of you have a high deductible plan? 1, 2, okay. So University of Michigan, so most people are in Premier Care, of course, which is not a high deductible plan. Some people may have VA coverage and the like, where you can get high deductible or consumer-directed health plans. These plans, imagine, if you're not in one, having a $3,000, $4,000, $5,000 deductible. Okay, just imagine that for a moment, because many of us are not currently in that place with our health insurance. That would require you potentially to think about your healthcare differently. Especially if you have a chronic condition. If you don't have one, imagine that you do. Or if you're a provider, think about your own patients. Imagine you have diabetes, and there's a certain set of services that you're going to need every year, no matter whether your diabetes is well controlled or poorly controlled. Hemoglobin A1C a couple times a year, urine microalbumin, going to need medications, blood pressure monitoring, an eye exam, test to look for loss of sensation in your feet, and probably some other services too, a statin. These are all things that high deductible plans do not cover underneath the deductible. People face the cost sharing for those services in high deductible plans. Okay, so again, we as providers, as patients, when you have chronic conditions, if providers and patients could work together to say, well, I've got these chronic conditions, what kind of care am I going to need for that condition over the next year? That way, perhaps I could use price information that is becoming increasingly available to estimate the cost of those services and be able to save for that if I'm financially able to. That would be one skill that is often encouraged among people with high deductible plans. You could, of course, use price information that is becoming increasingly available. Health insurance plans, there's not great data on this, of course, because there's not, people don't track well what private health plans are offering in terms of the bells and whistles that are attached to those plans. But increasingly, at least anecdotally, more health plans are offering price comparison tools to members in those plans. There are, of course, state-based efforts, regional efforts that are trying to, especially through all-payer claims databases, trying to communicate to patients or consumers the prices that they might face at different facilities. That is rapidly increasing in terms of the frequency and the spread of that. Patients could potentially use that information to choose where and when they will get health care. They also could talk to their clinicians about their cost-sharing challenges and try to make decisions about what kind of healthcare services, what to get and what services to forego with consideration of out-of-pocket costs in mind. This has been recently framed in the literature by Peter Ubel and others as the financial toxicity of healthcare. In many cases, if we are ordering low-value services for patients who are going to have to pay for them, we're probably doing them a disservice. And it may be the case that if we have conversations about whether this service makes sense for you, let's also take into account how much it may cost. That potentially, if there are more and more conversations like that happening, that could lead to better outcomes, not only medically, but financially for patients. And then there are actually reports in the media, believe it or not, of patients trying to negotiate prices for services. This actually takes advantage somewhat of the smoke and mirrors of healthcare prices, and the fact that often prices that have been negotiated between healthcare systems and plans are based on historically negotiated rates that are increased over time, and then there's a lot of cost shifting that goes on, especially around bad debt and things like that. And there are certainly plenty of media reports out there of people going to healthcare systems and saying, gee, I could get this service somewhere else cheaper. Would you be able to honor this price? And saying, yeah, sure, that's fine. Because increasingly as well, healthcare systems are faced with bad debt from people facing high deductibles and then not paying their bills. Right? So if potentially the healthcare system could accept a lower rate but actually get something instead of nothing, you could imagine many healthcare systems potentially being open to those kinds of inquiries from patients. So this idea then of helping people better use their plans, I think, raises some really fundamental policy questions. First of all, how often are people doing these things? I will say when I started to talk about this a few years ago, I got more kind of puzzled looks from audiences about, well, negotiating prices, using price information, that's kind of weird. I think this has gotten woven more and more in the fabric of media coverage about healthcare policy as well as people's experience in private health insurance plans. But it still begs the question, how often are people actually doing these things? Also, what kinds of patients are doing these things? Is it simply the people that often immediately come to mind, those who are more engaged in their healthcare, maybe higher levels of education, higher socioeconomic status, people who are more willing and able to engage in these kinds of behaviors, might be the ones who are more willing to engage in those behaviors. We'll talk about that in a second. When are people doing it? For what kind of healthcare services? And then also, how helpful are these things? Okay, so it may be the case that people may be using price information, maybe getting helped a lot, or maybe not. We actually don't know a lot about how helpful patients find these kinds of strategies. And then if we're thinking about implementing these kind of strategies more broadly or better supporting patients in high-deductible plans, it's important to know what kinds of things facilitate and impede their engagement in these strategies. So instead of doing what health plans typically do now is simply creating price transparency tools and pushing those out to plan members and then bemoaning the fact that people do not use those price comparison tools, maybe health plans could think differently about engaging in consumers and better support them to use their plans to get care they need at a price they can afford. So the way that we've been exploring these policy questions most recently then was through an internet survey that we conducted 2 years ago in partnership with GfK and their knowledge panel. So this was a survey of 1,637 GfK knowledge panel participants who'd been in a high-deductible plan for at least a year. GfK's knowledge panel used to be called Knowledge Networks. For those of you that are more familiar with that term, this is the panel that is currently used now for the National Poll on Healthy Aging, conducted by IHPI in partnership with AARP. For those of you that are not familiar, nationally representative internet survey panel of 55,000 U.S. adults. They can, I think, pretty reasonably claim national representativeness relative to other internet survey panels because instead of creating a website and having people opt into that, they do address-based sampling. So what they do is they look at people's addresses, they do probability-based sampling based on that, send people letters in the mail, say you've been selected to join this panel, they then reach out to them over telephone. If people do not have a computer, they give them one. If they do not have internet access, they give that to them too. They also then pay people to do the surveys. Very different kind of strategy than if you create a website and had people opt in. We administered the survey again 2 years ago. We oversampled people with chronic conditions because we were interested in whether people are engaging in these behaviors at higher rates when they have chronic conditions. Spoiler alert, they're not. I don't even have that on the slide because the rates were exactly the same based on whether or not people had a chronic condition. And then the response rate for the survey was 55%. So in our survey, we measured engagement in these behaviors in the last year. When people had engaged in one of those behaviors, we asked them what they did it for, what kind of healthcare service it was for, how much they felt it helped them, and in what way. When people had, we also asked them about what kinds of things facilitated or supported that engagement. What were things that helped you be able to engage in that strategy? When people had not engaged in those behaviors, we asked them why not. Because again, that's a really critically important issue or unknown in this particular area. Because a lot of these were new areas being explored in survey research for the first time, we had to do a lot of iterative testing in our survey development. So we did 17 cognitive interviews with people in high-deductible plans from all over America. This actually was think maybe 5 or 6 rounds of 2 to 3 people every time. We spent a very long time ensuring that we got to a reasonable level of validity in our survey questions and kind of intelligibility, and that the responses adequately reflected people's experiences in these plans. So hopefully that gives you some confidence that what we're measuring here has a reasonable internal validity. So these were the estimated characteristics of the population that we were surveying. You can see here the age breakdown. Again, these are non-elderly Americans in high-deductible plans, so people with private health insurance, non-elderly. You can see the rates of chronic condition, fair or poor health, the income breakdown, and then most people had employer-sponsor coverage, and many fewer had coverage through a marketplace. When we look at data from the National Health Interview Survey, probably the most long-standing data on rates of enrollment in these plans, our estimates of the population characteristics of people in high-deductible plans looks very similar to what NHIS has found. Okay, so how often are people in these plans actually engaging in these behaviors? Well, we found that the most common thing that people were doing in terms of these consumer behaviors was saving for healthcare they knew they were going to need in the future, what 40% of Americans in these plans have done in the last year. Okay, so this is not saving just generally. This is not saving for healthcare generally. This is saving for healthcare services you knew you were going to need in the future, is how we framed that question. A quarter of people had discussed the costs of a service with a provider. 14% had compared prices for a service in their decision-making, and 7% had tried to negotiate a price for a service. We ended up framing that question based on cognitive interviewing, based on, irrespective of whether that was before you actually got the service or after you got it and got the bill and then negotiated with the healthcare system. We found there was a lot of the latter going on in our cognitive interviews. And so we wanted to ensure that we, cast a pretty wide net for attempts to negotiate with providers. So which patients then in high-deductible plans are engaging in consumer behaviors? So what I'm going to show over the next several slides is going to be different characteristics of people, okay? And then the adjusted prevalence of engagement in each of those 4 behaviors by separated out by different characteristics. And then these are marginal estimates from logistic regression models, so this is adjusting for a whole host of other factors that could confound those relationships. So what we're looking at here first then is that people with higher levels of education were more likely to have saved for healthcare services they knew they were going to need in the future relative to people with lower levels of education. We also found that people with the highest levels of education with a graduate degree were more likely to have discussed healthcare costs with their providers. But it's worth noting, you'll see this again and again, that even for people with the highest levels of education, most people in these plans are not engaging in these behaviors. It's a very, very important point. We also, in our survey, we used a scale from the marketing literature. We were very interested in looking at whether people who are more likely to be bargain shoppers are more likely to engage in these consumer healthcare behaviors. And so this is, again, a scale from the marketing literature, and we then separated people into different tertiles by virtue of where they stood on that scale. And what we found is that, indeed, people who are more likely to be bargain shoppers are more likely to also compare healthcare prices and talk to their doctors about costs. But again, even the people who are, the coupon clippers and who are always looking for deals do not engage in these consumer behaviors at very high rates in these plans. Another really important point and why I earlier really hit on the issue of most people in high deductible plans do not have a health savings account. We did find that having a health savings account was associated with a much higher adjusted prevalence of having saved for healthcare services people knew they were going to need in the future. It's a really important point, I think, especially as it relates to potential policy interventions around these issues. We also wanted to understand other factors that could potentially mediate engagement in these behaviors, people being confident in their ability, taking into account all that would come along with being confident, having the resources, the tools, the knowledge, so on and so forth, the timing, being able to do it. We looked at people's level of confidence in being able to engage in those behaviors and how that relates to their actual engagement. And we found that people who had high levels of confidence in being able to save for care, discuss costs with the provider, and negotiate prices were indeed more likely to do so. But again, even people with the very highest levels of confidence, most of them did not engage in one of these behaviors. And then the final thing I'll show you relates to health insurance literacy and financial literacy. And we found that people with higher levels of health insurance literacy were more likely to have saved for healthcare services they knew they would need in the future, but they were not more likely to engage in any of the other consumer behaviors that we looked at. Another concept or construct that employers especially have been increasingly interested in is financial literacy, especially as it relates to things like retirement saving. We thought a lot about that as a construct and how that's distinctly different from things like health insurance literacy, numeracy. People being able to understand and use well money is a really important construct or skill in terms of being able to use these kinds of plans well. And indeed, we found people with higher levels of financial literacy were more likely to have compared prices for a service in their decision making. But again, even people with the highest levels of financial literacy, most of them did not engage in one of these behaviors. Okay. So that we looked at the rates of engagement in these behaviors. We looked at the factors associated with that engagement. Now we'll look at what kinds of services people are engaging in these behaviors for, how much they felt like it helped them, what kinds of things supported them in being able to do so, and what sort of things impeded or prevented people from engaging in those behaviors when they did not, which of course is a much more common scenario. And we'll go through these one by one. So first, looking at saving for healthcare. So we actually did not ask in our survey about the kinds of services for which people saved for healthcare. We wanted to do so. When we did that in cognitive interviewing, it completely fell flat. People did not understand it, and they did not think about healthcare saving in that way. They thought about generally saving for healthcare I would need in the future and a general bucket of services. Very hard to pin them down in a survey in terms of the individual services they saved for. So these were the perceived effects of saving. So just over half of people felt like it helped them get needed care and have less debt from healthcare. And a much smaller proportion of people said it helped them free up money for other things. So the fact they set aside money for healthcare, then they ended up needing healthcare, they had that on hand, and that then freed up their ability to use money for other things. What I'm showing you on these slides are just the three most common things that people told us in each of these areas. In terms of the things that facilitated saving, employer contributions to healthcare savings was the most common thing that helped people be able to save. People's health plans, and presumably communications from their health plans and the like, also was a common facilitator. So what stood in the way of people being able to save for healthcare? When they did not save for healthcare services, we asked them why not. And the most common thing that we found in terms of why people didn't save is they said, well, I didn't consider doing so. Another spoiler alert, this is the most common reason for people not engaging in these behaviors across the board for each one of them. People not thinking of doing it and planning ahead for their healthcare. Of course, the one response that immediately comes to mind, especially for people of lower socioeconomic status, not being able to afford to, that was a common reason, but it was not the most common one. And then, of course, people saying, well, it wouldn't have changed my decision. I think this, again, speaks a little bit to the fact in which people are using these plans. Even if I had set aside money for my care, I would have gotten what I was going to get anyways. So again, maybe planting a little bit of seed in terms of thinking about helping people use these plans differently when their cost sharing requires them to. All right, so that was saving for care. Discussing cost with a provider is what we'll turn to next. So what are people talking with their doctors about when they're talking about costs? The most common thing is a cost that is on the mind, of course, of a lot of Americans, especially those with chronic conditions and low incomes, and that's prescription medications and the cost of those. The next most common thing was outpatient visits, followed by procedures. So those were the top three. In terms of the perceived effects of having talked with one's doctor about costs, just under half of people said it helped them pay less for a service. You can debate whether that is high or low. I think we want that to be more helpful for people. But that being said, if you look at it from the other direction, there were many people that felt like having talked about costs with their provider indeed helped them be able to pay less for a service. Some people decided that made a plan with their provider that they were going to get the service but get it later at a time they could better afford that. You see a lot of reports about this in the media, especially and when you talk to people who are proceduralists, especially who deliver more elective or in some cases discretionary services, they find that their volume often increases at the end of the year, right, when people have spent through their deductibles and then they don't face the cost sharing. So deciding to put off a service until you could afford it would probably fit into that reason. And then deciding a service wasn't worth the cost. A big focus of IHPI and of my work and others is helping people avoid using low-value healthcare services. Right? So when people talk to their doctors about the cost of service, we don't know from this particular survey whether people should have or should not have gotten the service that they talked about. But I think interesting that many people felt like that helped them and their provider together decide that a service wasn't worth the cost to them. Maybe a good thing, maybe a bad thing, but a common outcome of those conversations. Things that facilitated cost conversations, somebody in the provider's office. That makes sense if you're having a conversation with somebody in the healthcare system. Hopefully somebody in the healthcare system would be helpful in doing so. And health plans as well were another common facilitator. In terms of things that stood in the way of cost conversations, there was no dominant reason. But the most common one was people not considering doing so in their healthcare seeking. Another thing we asked about, and this also emerged from the cognitive interviewing, the belief that providers can't help with healthcare costs. Okay, so we went in each of those questions, when people did not engage in those behaviors, we went with some commonly held beliefs of why people may not engage in those behaviors. So providers can't help was one of them, and that was something that just over 1 in 4 people endorsed as a reason. And in the way that we asked the question, we did not limit people to just one particular reason. We asked them everything that was relevant for them. All right, turning next to comparing prices. Again, just like in cost conversations with providers, the most common things people were comparing prices for: prescription drugs, outpatient visits, and procedures. Really, really common kinds of healthcare services for many patients and things that are often quite expensive for people in high-deductible plans. The perceived effects, again, people often felt like it helped them pay less for a service, sometimes felt like that helped them get needed care, and again, often helped people decide that a service was not worth the cost to them. In terms of the kinds of things that facilitated comparing prices, use of a website, that's often how this information is delivered, as well as support from a health plan. Looking at the barriers then, again, the most common thing is people not considering doing so. Another commonly held belief among people who did not compare prices was that prices don't vary all that much. We, of course, know that that's not true. There's huge variation in almost every kind of healthcare service in almost every market for a whole host of peculiar reasons. And so when people feeling like that's the case and that being a reason for people not comparing prices, I think that's important. All right. Finally and quickly, negotiating prices for a service. When were the 98 out of the 1,700 people who we surveyed trying to negotiate prices for services? So again, that wasn't 0 people. It was a small number of people, but there were some people that indeed had attempted to do this. Most commonly, that was for outpatient visits, and then followed by prescription medications and imaging tests. So you did not see that as much in terms of the other behaviors, but when you look at media reports, negotiating what one will pay out of pocket for an imaging test is one of the more common kinds of healthcare services among people who try to negotiate around which people may attempt to get a cheaper price. For the perceived effects, similar to what we found for the other behaviors, often people feeling like it helped them pay less for a service, have less debt from healthcare, or free up money for other spending. For the things that facilitated that, very similar to what we've seen for the other behaviors. And then why people, the many more people who did not attempt to negotiate prices, why they didn't do it. Again, the most common thing, although not tremendously dominant, the most common thing was people not considering doing so in their healthcare seeking, as well as closely followed by people saying, well, prices can't be negotiated. Okay. All right, so where does this leave us stepping back from it, and where are the policy implications, and circling back to some of the policy questions we were trying to address in our research? Well, I think the first thing is that few patients in high-deductible plans are engaging in consumer behaviors that could potentially help them get needed care at an affordable price. We know these are things that people in these plans are not doing very frequently, at least as of 2018, or I should say 2016 more precisely, when we surveyed people. Those who have engaged in these behaviors could be realizing more benefits. Across the board for each of those behaviors, when people engaged in them, about half of them, roughly, felt like it either helped them get needed care or pay less for health care. That also means at the same time that half of people who had engaged in those behaviors didn't feel that way about having done so. So people could be potentially standing to benefit more. We know that not considering engaging in consumer behaviors and having negative perceptions of the benefits that could come from engaging in those behaviors were commonly held beliefs and reasons why people are not engaging in these behaviors at higher rates. And I've hopefully illustrated for you in terms of the slides I presented earlier that the importance of these issues will only continue to grow as more people with private insurance face the challenges of high deductibles. Probably the most important slide that I will show you is this one, and where I think this points us for the future in terms of the roles of potential stakeholders to better support patients in high-deductible plans, because I think that our research points to some pretty clear directions in this area and some new opportunities. I think employers in particular could potentially offer health savings accounts alongside high-deductible health plans at greater rates. Again, most people in high-deductible plans do not have a health savings account paired with it. And if that could be done more consistently, and indeed if employers could also be contributing to healthcare savings at higher rates, that could potentially better support more people in these plans. They could also continue to develop programs that cultivate financial and health insurance literacy. Again, health insurance literacy seems to be an issue here, not necessarily the main one, but we know if people could understand their plans better, it's likely that at the very least they'd be able to more effectively and more consistently save for healthcare services. If people had higher levels of financial literacy, maybe they would use price comparison tools at greater rates, and so that would be the hope there. On the health plan side, again, what health plans unfortunately often do is that they create price comparison tools, they push it out to people, they see rates of engagement in those tools among people with high deductibles being in the realm of 5-10% if they're lucky, and then bemoaning the fact that nobody uses the tool. So it's that plus your explanation of your benefits that you get at the beginning of the plan year, and that's about it. I think if health plans could help people, could think about consumerism in healthcare as a health behavior that we could teach people around, that we could cultivate for people in these plans. Again, help them get the care they need at a more affordable price. That could be a new avenue for interventions and programs. Also, I think that when health plans do a lot of predictive modeling, trying to understand when people are going to need healthcare, when they're likely to utilize it, when we have GIS tools that identify where people are, and maybe try to take all of those data into account to try to make reasonable predictions about when people are going to need care, they could push information out to people, trying to prompt them to engage in those consumer behaviors at a time where doing so and interacting with that information may be more salient. That could potentially be a new opportunity. So thinking more about just-in-time interventions and how those could be delivered in this space. And then for healthcare systems, making prices available at the point of care I think is critical. If we don't have that information at the point of care and patients and providers are together making decisions at the same time as they're considering information like people's health needs, their health insurance coverage, their adverse reactions to medications, what healthcare they've gotten before, things that they're seeing in the EHR. If we don't have that cost information alongside that when people are facing the cost for those services, it's going to be incomplete information and lead to adverse consequences for people. Direct primary care practices are starting to figure this out. And their whole market for those kinds of providers is the consumer-directed healthcare space. And so they're often making very clear and very transparent the price that that individual person is going to face for that particular service. Not the charge, not the Medicare negotiated rate, okay, not the average cost of providing that service, the price that that individual will face for that service, and trying to take that into account in decision making. To be clear, I'm not suggesting that everybody should be going down that route, but I'm saying there's something to be learned about healthcare systems that have adapted to that and trying to meet patients in these plans where they're at and help them better respond to those challenges. And then also, potentially health systems could better facilitate conversations about costs of services, help providers better understand how to talk to patients about these things in the context of 20-minute visits if we're lucky in some cases. And then also make pretty clear for patients where can you go to talk to people about your bills, potentially even negotiate a lower rate for paying for your health care if the choice for you is to not pay that bill at all or maybe be able to pay something for it. So where do I want to take this work in the future? I am, as Dr. Richardson suggested in the very beginning, I do a lot of behavioral interventions, and I am deeply interested in developing and testing strategies to improve outcomes for patients in these plans, especially developing partnerships with health systems, health plans, employers, both on the clinician-facing side, helping us as clinicians better care for patients in these plans, helping patients in those plans use them better, maybe even doing both together to improve outcomes for these patients, to include reducing their cost-related access barriers, limit their out-of-pocket spending, and ultimately optimize the value of what they're spending for their health care. So this work has not been just my own. It is a product of a tremendous team that I've been really blessed to lead. And that's included Angie Fagerlin, who was here up until a couple of years ago, is now at University of Utah, who I continue to work with in the space, as well as Mark Fendrick, Helen Levy at ISR, Brady West, a tremendous statistician at ISR who's been really instrumental in this work. Chris Krenz, who's a research associate at Center for Bioethics, Social Sciences and Medicine, it's a mouthful. Betsy Cliff, a great doctoral student in health management and policy, who is a soon-to-be health economist. And then Simona Singh for the School of Public Health as well as Tim Peterson. We've all been working together in this line of research, and it's been a really fun ride. I've also gotten great support from colleagues at the Detroit Regional Chamber, who's really helped us keep our finger on the pulse of questions that are important to employers and health insurers in this area and ensuring that the information we're generating is going to be relevant to policymakers and practitioners. Jonathan So is who I've worked with most closely in that work and has been really tremendous. And then this work has been funded and supported by M.P.H, the Robert Wood Johnson Foundation, and then as well supported by a Career Development Award from the Department of Veterans Affairs. So I'm grateful for all of that, and I am grateful for your attention, and I look forward to your questions.
So the whole concept of insurance is to pool risk, right? Because there are sort of unpredictable risks that are relatively rare across the population. And if it was easy sort of to plan ahead and save for these risks, people would be doing it without insurance and you wouldn't need insurance products. But we know that that's not how healthcare works, that healthcare spending is unpredictable and it varies, there's a lot of variance from year to year about how much you have to spend. And so when you spend a lot of time talking about health savings accounts and expecting people to put aside money in a health savings account for it, it sort of seems like an oxymoron to have insurance that you have to plan ahead for and save for yourself on. It doesn't seem like it makes sense, but I think where we are is we've gotten to this point where chronic disease management is folded into the high variance insurance plan coverage, and it's distorting things in a weird way. And I'm just wondering, is it really possible for people to plan ahead for what they're going to have to spend in some efficient and effective way? Is that really limited to chronic disease management, which they know they're going to have to spend money on? And should we maybe be pulling that out of the whole insurance model and putting it into something that isn't a risk pooling device? And then just a point of clarification, my patients have told me that if they put money into a health savings account and don't spend it, it goes away. Is that accurate?
That is not true, but they may be thinking of a flexible spending account or an FSA. So one thing about HSA is the money you put into it, it is tax deductible, so you don't pay taxes on it. You can actually deduct it from your taxable income. You can then put that in account, it rolls over year to year, and you own it, right? So you can take it away with you if you leave that employer or what have you. Use it for credible medical expenses, and you don't have to pay taxes on that. And then people can withdraw that on the back end once they hit 65. They have to pay taxes at that point. If you pull that earlier, there's a 20% penalty in addition to having to pay income tax on that.
And so in your numbers where you said people had health savings accounts, you didn't include flexible spending accounts?
We did not, no. So we use the National Health Interview Survey wording about that item, which included things like health reimbursement accounts, but makes a clear distinction between that and FSAs. So we were very confident we were not capturing FSAs there.
And what percentage of people with these high deductible accounts have flexible spending accounts?
That I don't know. I'm not sure. Yeah. But so that's, and HSAs are kind of tricky. You've obviously got to have a lot of financial literacy to be able to use that, and high levels of education and numeracy and all of the rest. So it's clearly not a panacea to that problem either. I think, your point is an excellent one about chronic disease management. At some point, you're absolutely right. I think from a theoretical standpoint, that's a point that's made. I remember getting my M.P.H here in health management and policy. We were trying to ensure, another goal of insurance is to protect people against catastrophic financial losses, right? Not pay for routine, predictable services. But that, for better or for worse, is what health insurance has become to a lot of people. Now, maybe that's swinging back in the other direction, that, as you have more catastrophic plans, that's indeed what they do. They still provide that, but they don't provide what we are now used to that we had under first dollar coverage, is paying for everything. So the pendulum swung back to maybe perhaps a little bit more of the true goal of health insurance coverage. But where that sits then for people with chronic conditions is a major issue. And again, Mark has been working on that piece for, could we allow no cost sharing under these plans for chronic disease care? That may be an opportunity. That has proven a lot harder than one might think, but if you think about Washington, maybe that's not surprising. I don't know. Yes, John.
Jeff, thanks for your presentation. I have a two-part question, one on the provider side and one on the health plan side. Do providers like the University of Michigan know when patients have high deductible health plans? And if they do, could they flag it for us as providers?
They do not know, but they could. And I would love for someone to be willing to test that as an intervention. I think that simple flag may lead to different conversations and may lead providers to be more attuned to some of these issues, especially, sure, providers may not know the exact dollar amount, but I think most of us know what are some of the big ticket items and which are to a lesser extent, especially too as we think about medications and things. I think that simple flag and making that clear for providers would lead to different outcomes, and I think we should try to do that. I will say that Michigan Medicine theoretically knows that somewhere, right? They may know the name of that health insurance product. They may have ways of being able to estimate from the allowable rates and what people pay and things like that nature. They may be able to estimate whether somebody's in a high deductible plan. That's not easy for them to know. But you could also imagine a world in which that is pretty clearly communicated at the point of care and that being beneficial.
Or whether, like at patient registration, we could ask patients or do it directly with Blue Cross Blue Shield if they're one of our dominant payers, ask them to share that information. My second question is on the health plan side. When a high deductible health plan is offered, do they bundle it with other tools that health plans have to keep prices down, like in-network versus out-of-network pricing, reference pricing, narrow networks? Do people get the benefit of those negotiated discounts if they're in a high deductible health plan before they reach their deductible for services that they use?
So just so I understand that correctly, John, so you're saying when people are underneath the deductible, are they able to take advantage of some of those things?
Out of pocket, but the provider knows they're in United or Blue Cross deductible health plan. Do they get the benefit of negotiated discounts?
They do indeed. They do indeed. Yeah, so an interesting thing. So they do, right? So for example, if you had Blue Cross coverage, you would pay the Blue Cross negotiated rate even if you're the one that's paying for the whole thing. There are a limited number of circumstances where sometimes that is actually more expensive than what. So some imaging facilities, for example, have tried to undercut that and are trying to win on volume. And they say, listen, this is our retail price for this. Don't even use your insurance if you have a big deductible, because that may well be cheaper than the negotiated rate with your health plan. Talked to a reporter at the Philadelphia Inquirer about this a couple months ago, and had encountered this again and again with different patients who, when they went through their insurer, they actually paid a higher rate, surprisingly. But that's currently how that works, is you get the benefit of what they negotiated. Yeah. And we have just an announcement, we're like right at 5, so I'm happy to stay as long as you guys want, but sorry.
So I guess I'm curious about, I know that you looked at specifically people with chronic disease, but how do these behaviors change for people with chronic disease versus somebody who has a catastrophic event during the year? And do we have different interventions that we can then be giving people who are experiencing like a fall-off of a deck, a motor vehicle accident, versus somebody who we know up front is going to be managing their diabetes going into the year?
Yeah, it's a great question. So maybe I'll just rephrase that a little bit, which is that what sounds like you're asking about is, could there be different interventions for different kinds of health issues for people in these plans? I haven't really thought of that, but yeah, I think it's a great point. Maybe again, that if you have a chronic condition, ask your doctor what kind of care they think you're going to need next year. If you've got diabetes, or the things that I'm definitely going to need when I'm in this plan, tell your provider you're in a high deductible plan, right? So there may be certain skills. You have a catastrophic condition, I think even the most staunch proponents of consumer-directed healthcare, when they're honest about it, would say that people should not be comparing prices when they're having crushing substernal chest pain on the way to a hospital, right? That makes no sense. But it may be to the negotiation piece. If you're stuck with a big bill from some catastrophic event, you should talk to the healthcare provider about that bill and whether they'd be willing to accept less. All they can do is say no. It turns out sometimes that actually helps people. You could imagine something like that. Again, that would need to look very different, but that's a great point, and I'll think more about that. Thank you.
Why don't we adjourn and move out to the lobby, and then we can keep peppering you with questions.
I would love that. Thank you. Thank you, everyone.